from Dr. Shrouk. She's a consultant in pediatric emergency medicine at Alder Children's Hospital in Liverpool, in UK, and an emergency department research lead. She will present for us a talk in our PediEM Updates Journal Club, the first 60 minutes in PEDS major trauma, evidence-based ED priorities. So, Dr. Shrouk, the floor is yours.
Thank you so much, Dr. Yara. I'm really pleased to be speaking with you today. Can I just double check that you can see my screen and that you can hear me? Okay,
Yes,
wonderful,
that's
lovely,
perfect.
thank you. It's great to connect with international colleagues around the world, and it's honestly, it's a pleasure for me. So I'm going to get started. I'm a consultant in pediatric emergency medicine at Alder Children's Hospital in Liverpool. Liverpool is often better known for its music or its football clubs, but actually it has one of Europe's largest and busiest standalone tertiary children's hospitals. The emergency department is a major trauma centre, or the equivalent terminology is a level 1 trauma centre. And we are a specialist paediatric emergency department. And I've worked in Liverpool for about 15 years now. So just to say, I have no conflicts of interest. Well, when Dr. Yara first contacted me to discuss pediatric major trauma, especially in the first 60 minutes, there's a couple of things. Firstly, I'm not talking about all of pediatric trauma. That would take a couple of days to go through. I'm going to focus on some key aspects within that first hour. It's often termed the golden hour. This was kind of coined in the 1960s and 1970s because the most of the deaths from trauma actually occur within the first hour after injury. Rickenbeck and his team in 2024 conducted a retrospective study to test the hypothesis that the mortality risk is actually non-linear, and to try and determine a threshold for pediatric trauma. The initial theory was that, if you delay your attending hospital by 5 minutes, that adds on a certain number of percentage points of your risk of mortality. But didn't quite really see that in pediatric trauma, and so they looked at this using the American Trauma Registry. This has a database of 700 trauma sites, and in their study they included over 60,000 patients, and they found that the mortality in the first hour was non-linear against time, and that the lowest mortality risk was a presentation to the hospital of about 45 minutes. So not the golden hour, but maybe the golden 45 minutes. And they concluded that presentations earlier to hospital actually might reflect children who are actually more critically injured, who are at risk of imminent death. And pre-hospital care might have instituted the scoop and run approach of, we need to get them to hospital as soon as possible, but actually they're already in the process of dying. So in my talk, I'm going to talk about mainly a UK-based pediatric trauma experience, drawing on my experience a little bit as well. I'm going to talk about systems. I'm going to talk about trauma systems and the evidence for trauma systems. And then I'm going to specifically focus on pediatric traumatic brain injury. I'm going to assume the APLS or EPALS or ATLS or whatever structured resuscitation approach that you have or so I'm going to assume that, so it's not actually going to be discussed. I'm not going to discuss it in that kind of format. Okay, but I've tried my best to make this interactive. So just to make sure that we're on the same page in terms of what are we talking about when we talk about major trauma. I'm going to pose a question to you, and I'd like you to answer the question of what is major trauma. So if you get your phones at hand, I'm really hoping the technology works. Okay, can you scan the QR code or join the interactive platform at the website there, and you have to input the code. There are a series of questions in this talk. I'm hoping that it works. And when somebody starts typing, oh, you see, I can see 2, 3 people have joined. When somebody starts typing, your answer will actually supposedly come up on the screen. So I'm not after reams and reams of text, but some pertinent things that you think are included in a definition of what major trauma is. Yara, is it working? Oh, yeah. Okay, great. Oh, yay. Oh, this is exciting. Okay, great. So we have multi-system injury or serious injury. Serious multiple injuries which affect a patient life. More on multi-system injuries, a single or multiple traumatic injury in main life treating organs or systems, high mechanism involving multiple systems, a GCS of less than 8. High risk of trauma causing death. Okay, are there any more coming on? Yeah, so trauma requiring immediate intervention. Okay. Multi-system injury. Serious injury with a high risk of death or disability that requires immediate coordinated resuscitation. Okay, right, I'm going to move on. And we'll, so this is just a little practice run for the questions that are going to come in the rest of the presentation as well. Okay, so yes, so all of that and some more. So definition according to NICE UK guidelines, and NICE is the National Institute for Clinical Excellence guidelines, has defined major trauma as an injury or a combination of injuries that are life-threatening or could result in long-term disability. And they usually have an ISS score of over 15. So an injury severity score or an ISS score is a calculated score. It squares the top 3 worst injured body areas as graded by another score called the Abbreviated Injury Scale. The Abbreviated Injury Scale, or AIS, is a 6-pointed scale for 6 different body areas. And a score of 6 in any one of those body areas on the AIS denotes an unsurvivable injury. And that automatically gives you an ISS score of 75, which is the maximum score. The main issue with ISS is that it does not account for multiple injuries within the same body part. It only adds the worst body part affected. So if you had a fractured skull and a brain bleed, you'd have to judge, is the brain bleed the worst one? And that would be the only one that's counted going forward. There are, of course, other injury scores, and this table illustrates the work done by Sultanoglu and his team comparing their performance. The top 3 well-performing scoring systems are the PS14, the ISS, and the NISS in pediatric trauma. The UK uses the ISS score. These scores aren't designed to be used in the emergency department. The benefit of the score is that it allows for much larger population level research in trauma in predicting mortality and morbidity. And it feeds into a system of improving trauma services. Data is key. Now, trauma is a significant cause of mortality and morbidity in children. It is the overall leading cause of death in children over the age of 1 in developed countries, and it doesn't reduce until around about the age of 40. So in 2018, the Royal College of Pediatrics and Child Health in the UK produced a report of the leading causes of death in children and young people. If you separate it out by age bands, the age 1 to 9 years, it's the second most common cause of death. And in the over 10 years old, it's the leading cause of death. But the combined score, the combined rate is that it's the leading cause of death. And this is reflected in very many developed countries around the world. Trauma is a huge burden on healthcare, from public health resources to pre-hospital care, to hospital expertise, to the provision of care, to rehabilitation, community support, and leaving children with potentially lifelong altering effects. The risk of death from major trauma is actually higher in children who are deprived, children of a lower socioeconomic state, and unfortunately children who are Black or Asian. They have a threefold increase in mortality across any region, any aspect at all, which is really quite saddening. And there's a lot more work to be done for that. A lot of my talk is going to focus on mortality and the efforts to reduce it. So another database called the National Child Mortality Database, the NCMD, in the UK published a report specifically on traumatic incidents and death relating to traumatic incidents in 2023. And it demonstrated that the cause of the traumatic death is predominantly road vehicle collisions, of which being in the vehicle or being a pedestrian are the highest kind of breakdowns within that category. And these are very similar to other areas of the world. Al-Munif in 2021 published a 6-year retrospective chart review of causes of death in children associated with one tertiary specialist children's hospital in Saudi Arabia. And they demonstrated that of the 1,152 patients included in their study, 15 of those were preventable. And the majority of these deaths were, again, due to injuries and the top causes of being a passenger in a car or a pedestrian. Then the UK has national trauma registry databases. It used to be something called TARN. For many, many years, it used to be TARN. And now it's moved over to something called the NMTR, which is the National Major Trauma Registry. And this has further granulated information about injuries, not only the ones that have caused death, but also those who have triggered a minimum threshold for reporting. And that minimum threshold is either one of time in hospital over 72 hours, admission to HDU or ICU, or transfer to a definitive care hospital or death in hospital, even if that's in the emergency department. What is clear is that pediatric traumatic head injury tops the list of injuries by far. And these are due to features unique in children. They have proportionately bigger heads than adults. They rely on systems built by adults to protect them. What's also of note is that a lot of these children will actually have multiple body parts injured. Okay, so the next poll. Okay, so again, scan the screen, or I think you should just be able to move on to the next question. So if you've already scanned in. So this question is, what are important aspects in developing a pediatric trauma network? We have the data, we know the problems. Now we have to do something about it. And Just so that the time doesn't run away from us, I'm going to just set a little timer for about a minute and a half. Okay, so system design, pre-hospital care, a standardized pathway, starting from community awareness, team readiness. Transfer system. Yep, right, we got about 10 seconds left before we move on. Standardized protocols and guidelines. Governance. Yep. Okay, right, we're moving on. Absolutely. All of those things are particularly important. In the and I'm going to talk about how a trauma network really benefits patients. In the late 2000s, national reports in the UK on trauma management illustrated significant variations and serious failings in the organisation of trauma care. Trauma was previously managed in any acute hospital with an ED, irrespective of the resource availability or the clinical experience or the expertise of the people receiving the patient. And these were used as political drivers to develop a centralised service. So in the UK, in 2010, regional trauma networks were developed, with London being the first one to go live. And in 2012, they spread across England. Within 5 years, there was an increase in odds survival by 19% for patients who reached hospital alive. Cole published a narrative in 2022 to describe the inclusive regionalized networks of care and highlighted 6 areas of a function of a network. But there's still a lot of work to do. But these are from models which work. So one is pre-hospital care, the use of triage tools, paramedic training, clinical protocols. There's some issue with data linkages. So sometimes the data doesn't follow the patient because it's on a different system. There's facility-based care. So there's concentration of expertise within an area. And that area is mandated to receive trauma patients, like the level 1 trauma center in the region. There's a clear transfer policy from a trauma unit, so a level 2 or a level 3 center, to the trauma center, and it's mandated care provision. These trauma centers, these level 1 trauma centers, cannot refuse a trauma patient. They have to accept them. Now, with that is a trauma network. And the UK utilises a hub and spoke model. So there's one trauma centre, level 1 trauma centre, and there's multiple trauma units around. And within that trauma network, they have one governance structure, one type of pathway for a particular kind of condition or illness. And they get together and have specialist training days and help educate everybody within the region. There was a real worry amongst clinicians who would end up working in trauma units, so level 2 or level 3, that they would de-skill. And there was a worry that for their progression and for their clinical teams, that would happen, and they would actually be left in a more vulnerable state. So there is much onus on trauma centres to be able to provide that education and that training as well. We've talked about trauma registries and mandated reporting. That informs research, that informs education, that can highlight some specific issues within regions. The UK has just, they have e-scooters now around, and what we're seeing is a rise in significant injuries in e-scooters on adults and in children. And these trauma registries really, really help in um, further research education, but also in policy shaping and policy making. Rehabilitation. So within the trauma network, there has to be a system for rehabilitation. The regions mandate a named team within a specific location, but these are still a little bit patchy around the region, around the country. And then it needs massive financial backing. It has to have a standardized approach, so it has to have government funding, and the funding usually follows the patient, so it doesn't get left in an area where the patient doesn't need it. So data from mature networks show that the overall survival is better at a pediatric major trauma center or an adult major trauma center with staff trained specifically in pediatric emergency medicine. And there were specifically better outcomes for children at pediatric major trauma centers for head and abdominal trauma. Okay, now we're going to move on to pediatric traumatic brain injury. Chances are that if you work in an emergency department, you will see a child attend with a traumatic brain injury. It's such a common presentation. There's a huge amount of children who injure their head and require inpatient services. It's the leading cause of mortality and trauma, and severe pediatric traumatic brain injury, or TBI, carries a mortality of about 40 to 50%. It's huge. So we're going to illustrate pediatric traumatic brain injury with a case and some interactivity as we have already done. So I'd like you to meet Bob. Bob is a 7-year-old male who was out playing on his bike. He was knocked over by a car traveling at a relatively low speed. He's reported to have briefly lost consciousness, but he regains it at the roadside and he stands up. He gets into the driver's car, who would offer to drive him home. He's a bit upset because his bike and the front wheel is a bit mangled. At home, Bob starts feeling unwell. He vomits once and he starts complaining of a headache. His parents give him some paracetamol. He starts crying with the pain, and then the parents decide to call an ambulance. The ambulance arrives 35 minutes post-injury. And remember, we're talking about the golden hour or even the golden 45 minutes. And they make their assessments. They call through to your department when you're on shift to inform you that they're bringing Bob in, and they report his GCS to be about 14. But he climbs into the ambulance himself, and the first observations that are called through are all normal. Okay, so get your phones out again. And the next question, when it loads, what are your next steps? You're going to receive Bob. He hasn't arrived yet. You've just taken the call. Choose the answer which is most aligned to what you would do. So the first one might be, well, Bob's low risk for a severe TBI. It was a low mechanism. His GCS is okay. We would just triage him as usual. Or Bob might have a severe traumatic brain injury, but you think it's isolated injury. He'll need a CT scan, so prepare CT that they'll be receiving a patient. Or you think that he's at risk of severe TBI and he needs a full trauma response from your emergency department. And again, I'm just going to give you a minute to vote. Come on, you guys have got to commit. Okay, just a few seconds left before we close the vote. And it's an even split between, he might have a severe TBI, but you think it's isolated, informed CT that he'll need a scan, or actually he's at risk of a severe TBI and you're going to put a trauma call out. Oh no, okay, right, last minute voting there, tip the balance. Isolated injury, might need a scan. Okay, so first of all, what we're going to do is we're going to talk about the classification of traumatic brain injury. The most common classification is GCS, so the Glasgow Coma Scale. It was initially used in 1974 as a clinical instrument for the structured assessment of the level of consciousness of individual patients. The classification of TBI is by clinical severity, and that's linked to the GCS, and they group the GCS in terms of mild, moderate, and severe. It is only one clinical parameter. Specifically, however, the motor function within GCS is the most sensitive to severity. And you might have neurosurgeons specifically asking you, can I have the breakdown of GCS in terms of eyes, verbal, and motor response? In the setting of TBI, there's well-documented inverse relationships between the GCS and the incidence of positive findings on scan. So the lower the GCS, the more likely there's going to be a positive finding on CT scanning of this person's brain. But there is continued controversy about this mild kind of category. So mild category includes anything from 15, which is minimal or normal, to 14 and 13, which actually might include concussion, loss of consciousness, or post-traumatic amnesia. And in some clinical guidelines around the world, so Australia, it's decoupled GCS of 13 from that, and they term it something differently. The other thing is that concussion is often used interchangeably with mild TBI, but neither of those have got specific definitions to them, and it becomes quite challenging. So studies have shown that if you're classed as having a mild TBI, so GCS 13 to 15, the mortality is at 0.1%. Moderate TBI, GCS 9 to 12, mortality is at 10%. And severe TBI, so GCS of less than 9, mortality is 40 to 50%. The column in the middle with the numbers on, 85%, 9%, and 6%, reflects the proportion of children that we see in our emergency department with a low GCS. So of all our numbers, and we see probably about 2,000 children a year with traumatic brain injury presenting at any level of traumatic brain injury presenting to our department, 6% of those will actually have a severe traumatic brain injury. Now, GCS is highly relevant in clinical practice and it's a really familiar score, but it has its limitations. Specifically, there's a loss of crucial information regarding severity. It's only one model. It ignores other modalities which might help with diagnostics, so imaging or neurobiomarkers. You can't meaningfully select patients for therapeutic interventions or trials because within one group, it only talks about severity. It doesn't cause about cause or effect or outcomes. And there is some stigma and biases with the terminology. Mild actually indicates that a person will recover quickly. And that kind of terminology actually forms barriers to service development. That's why in some circumstances in the UK, mild TBI services, so concussion services, are only, for pediatrics, are only in their development. Because of this, the National Institute for Health, the National Institute for the Neurological Disorders and Stroke, developed an international consensus to describe a new classification of TBI. The group describe that the assessment is for all ages and all severities, and they included international experts and patients with lived experience of a traumatic brain injury. And the result that they had was that they developed a 4-pillar framework called the CBI-M. And there's now some consideration about how they're going to use that in practice. At our centre, we introduced some concussion screening a few years ago, just concussion screening a few years ago. It completely failed because it took too long. So it'd be really interesting to see how this framework is put into practice. I'm not entirely sure it's going to be an ED framework. It might be something that happens later on the wards. But these are the parameters. So they talk about the pillars, and each pillar of these four pillars has an essential assessment and an extended assessment. The first and most important pillars that the authors highlight is the clinical one. And they've used GCS, because everybody knows how to use it, and pupillary response as an essential assessment. But they also highlight the significant finding of post-traumatic amnesia as an important inclusion in the extension element. However, how do you figure that out in a 2-year-old child? You're not going to do that. So that's why that's in the extended assessment and not in the core assessment. Biomarker use is the second pillar. Brain tissue, when it's damaged, it leaks proteins into blood, which can be measured. And the most common proteins are GFAP, UCHL1, and S100B. And they've been developed as point-of-care tests in emergency departments and can yield a result within 15 minutes at the bedside. They're validated in adults, and these tests have actually been added to national guidelines in Scandinavia and France as their national traumatic brain injury guidelines for adults. There's lack of information to use in children at present. No one quite knows what the normal reference ranges are, so a lot more research is needed. But there was a study in France last year which examined GFAP and UCHL1 via the Abbott Alinity iStat machine. There are other machines, of course, in over 700 patients, and they showed a correlation with injury. In adults, these neurobiomarkers have actually helped modify rates of neuroimaging, so, with reports in Scandinavia of decreasing CT scan use, particularly in mild or moderate category, by about 30%, which is actually quite game-changing, actually. But there's no such studies in children at the moment. Imaging is the third pillar. CT scanning is the gold standard and recommended in multiple national guidelines, radiological guidelines, and in national head injury guidelines. Despite its risks of radiation, it's quick and it provides information required by ED clinicians at the time. Is there a bleed? Is there a fracture? MR scanning is much more sensitive and doesn't carry the risk of radiation. However, they're technically more challenging. Ask any 2-year-old to stay still in an MR machine for 2 minutes when they've got a head injury. It's near enough going to be impossible. The modifier pillar is the final one, and that includes psychosocial elements, environmental elements, or particular patient-related factors that may indicate modification of outcomes. Okay, back to Bob. He now arrives in the emergency department 45 minutes after injury. We haven't really got much time left. He's deteriorated en route, and the paramedics arrive saying that he's now much less responsive than he was, but seeing as they were only a short distance away from the hospital, they decided to speed up and put the lights on rather than stop and intervene. On your assessment in the emergency department, Bob is not breathing adequately, and his left pupil looks dilated and is very sluggishly responding to light. Very sluggish, almost non-responsive. He is not immobilized. What are your next actions? Here comes the poll. So again, we'll have 60 seconds for this. So X, A, B, C, D, liking the emoji. Activate the trauma team if you haven't already, and apply the C scholar, a cervical collar. Secure the airway, briefly hyperventilate. Prepare for intubation. Somebody is drawing some diagrams on there as well. I'm not entirely sure what they mean. Do an EFAST. Where? Hypertonic saline, do a trauma panel. Secure the airway. Blood pressure measures. Get a CT of the brain. Activate the trauma team, intubation, start, I presume that means treatments for high raised intracranial pressure, neuroprotective measures. Okay, all right, so we're going to move on. These are all good thoughts. We'll go through them one at a time. So essentially what we need to do is we need to use methods in the emergency department to manipulate raised intracranial pressure, because this is what he has. He has raised intracranial pressure, and if left untreated, it's going to kill him, and it's going to kill him in the emergency department. And what we also need to do is prevent secondary brain injuries. And we have to do that in all a very, very short amount of time. And there are key treatment strategies in the literature and in varying degrees in national guidelines, and each country does something slightly different. So the UK uses NICE head injury guidelines, which were updated in 2023, and they're based on the Chalice guidelines. And Chalice was focused on who needed a CT scan rather than who didn't need one. And that reported sensitivities of 90% and a specificity of 78% in picking up an injury on CT scan. The NICE guidelines have a sensitivity of over 93% for clinically important injuries, which may affect neurological outcome. The current NICE guidelines are more of an amalgamation of guidelines and opinions to try and identify who are safe not to scan. And so leaning a little bit more on the PECAN rules, with a bit more of observation in there than scan immediately. And there are, of course, other head injury guidelines. We've mentioned Chalice, PECAN, and there's another one called Catch7. But these are the things that we're going to talk about. So we're going to talk about ventilation strategies. We're going to talk about hyperosmolar therapy. We're going to talk about tranexamic acid, temperature control, C-spine control, and other body systems. Because what you want to do is you want to package this child up so he is safe to image and survives to getting to theatre, getting to the neurosurgeon, or getting to intensive care, depending on what the scan shows. So that's the aim of the emergency department, is to stabilize and to move on. And those are the two outcomes for this child. You want him to be alive going into theatre. You want him to be alive going into intensive care with an image of his brain. Okay, right. What's the next poll? Okay, the next poll is, so we're going to talk about ventilation strategies. Would you hyperventilate to lower the PCO2? And this is just a poll, so it's either yes or no. So you just choose one or the other. Because somebody mentioned it before about briefly trying to hyperventilate. So one for no and one for yes. Another for no. Yes. Oh, so we're 50-50 at the moment. No. Okay. All right. Tipping the balance slightly. You've got about 20 seconds left to vote. No, 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 no. Okay, all right. So some people say no, and a minority say yes. So let's talk about ventilation. Well, intubation and ventilation are very specific treatment modalities for airway protection and respiratory failure. Remember, hypoxia kills far faster than hypercarbia. So oxygenation, get that in because that's going to be a real big problem if you don't address that. Once that kind of ventilation, once that procedure is done, um, we can talk about how fast do you bag the patient? How do you what are you going to measure on your end tidal CO2 monitoring in the emergency department? Well, hyperventilation has been used since the 1970s as a treatment strategy to manipulate raised intracranial pressure. Hypocarbia causes cerebral vasoconstriction and a reduction in cerebral blood flow. It was thought that after an injury, children's brains become hyperemic, so more blood flow goes to it. So actually a reduction of this could be useful. However, subsequent studies have shown that hyperemia is actually uncommon or it's actually patchy within the brain after an injury, and that a low cerebral blood flow is actually associated with poorer outcomes than a high cerebral blood flow. So a low CO2 is also thought to actually limit the capacity of the buffering capacity of the CSF, which might actually increase vulnerability to abrupt ICP changes. So the messaging or the evidence at the moment and what the recommendation is from the Brain Trauma Foundation and which is the American guidance for traumatic brain injury and the NICE guidance for traumatic brain injury in the UK is that aim for normal ventilation, aim for a normal PCO2. The brain loves normal things. It doesn't like things slightly out of range. So the next poll, right, what we're going to talk about. Somebody mentioned some IV therapy to manipulate ICP. So you think he needs the IV therapy, right? Which agent would you choose? So there's a choice. Hypertonic saline 3%, hypertonic saline 7.5%, hypertonic saline 23.4%, mannitol or phenobarbital. And we're just going to give you a few moments to score. It's nice to see. Okay. Okay, so 4 for hypertonic saline. At the moment, any more for any more? No? Okay. Let us move on. So let's talk about hyperosmolar therapy or drugs to manipulate raised intracranial pressure. They were initially introduced in 1919, and mannitol and hypertonic saline were the two most commonly used. There's favour leaning towards hypertonic saline, although there's no clear, strong evidence to actually back that recommendation. Studies performed in children were small in number, didn't have any controls, or actually lacked robust outcome measurements. There was a meta-analysis that was performed by El Sabri and team earlier this year that demonstrated that there was only 14 studies published with a total of 680 patients. Now, if you think about how many children are injuring their heads across the world, 680 patients is a really small amount. The conclusions were that there was no significant differences in mortality, survival, inotropic use, admission to ICU, but that hypertonic saline probably has a more predictable and faster reduction in intracranial pressure than mannitol, and it also has the benefit of volume expanding to support systemic blood pressure rather than mannitol, which tends to dehydrate. And that's the aim. It's eurovolemia rather than dehydration. There are, however, problems with hypertonic saline, particularly repeated doses or when you get to a stage when a patient has a sodium of 100 over 160. They were then associated with a range of potential side effects, including bleeding, anemia, diuresis, DVTs. However, it seems that institutions like the Brain Injury Trust, Brain Injury Foundation, and NICE will actually recommend hypertonic saline at 3% in small boluses. It can be repeated for use in the emergency department. It's really easy to give. These charts here show Al-Sabri's work of looking at mortality and survival, and the risk ratios are quite close to the line and they extend over the line, so it just indicates that there's no significant differences there. Okay, next poll. You've heard about tranexamic acid use from your adult emergency medicine colleagues. Should you use it on Bob? It wasn't that something that was mentioned in the previous question. So lots of people are saying no. Oh, one person says yes, definitely. Oh, two person. Oh, okay. Moving the tide here a little bit. Any more voting? Or the no's will have it. Okay, right. So we're going to stop polling now. The no's have it on this one. Let's talk about tranexamic acid. It's an antifibrillinic agent that stops bleeding by competitively and reversibly inhibiting the activation of plasminogen to plasmin. And it specifically binds on plasminogen, prevents it binding to fibrin, and thus stopping the clot from dissolving. So it stabilizes a clot and it allows that clot to remain intact for longer. There's a series of wonderful studies, called the CRASH studies, CRASH 1, CRASH 2, CRASH 3, and there's CRASH 4 as well. And these are large international multi-center studies on adults. The first was the use of tranexamic acid in major hemorrhage in trauma patients by pre-hospital teams arriving to these patients. And it showed that it reduced, the quicker that you give it, it reduced bleeding from massive hemorrhage out in the field. CRASH 3 was very specific about isolated traumatic brain injury in adults, and they used 1 gram as a bolus in the pre-hospital environment, so paramedics used it, and they looked at multiple outcomes. And these were thousands of adult patients that were used, and what it showed that overall there was a reduction in mortality, but not quite enough for significance. But when it was broken down into mild, moderate, and severe classifications of head injury, what they found is that in specifically the moderate group, if it was given within 3 hours of injury, it reduced their odds of dying by 22%. That's huge. The pediatric dose has been extrapolated from an adult dose. So 15 milligram per kilo bolus of tranexamic acid is given as soon as possible. In the UK, the paramedics give it on the roadside. It has a time response benefit. So every 15-minute delay is associated with a 10% decrease in benefit of the patient. And in the emergency department, it can be followed up by a continuous infusion. There is a pediatric study in America that's happening at the moment. They've done a pilot feasibility just to see if this study will recruit. It's called the TikTok study, and it recruited 30 children tranexamic acid versus placebo, standard dose tranexamic acid, high dose tranexamic acid, and placebo. Of course, in a feasibility study, you can't mention anything about outcomes. It's just all about will this study recruit? But that study is hopefully going to start soon. In the UK, the national research body, the NIHR, has actually indicated that further funding for tranexamic acid studies is not going to be granted, or is actually going to be less favourable to be granted because of the overwhelming evidence of the effects of the benefits of tranexamic acid in massive hemorrhage and isolated traumatic brain injury, and the safety profile in trauma. So I hope I've given you some information about TXA there. Right, next poll. You've read that hypothermia affects mortality in newborn asphyxia. Should you try this on Bob? So there's options of yes, total body hypothermia, yes, but only head cooling, no, not in the emergency department, maybe on ICU, or no, not anywhere at all. No, not anywhere, not in the ED. It's too complicated in the ED. We've got enough to do in the emergency department. Okay, all right. So not in the ED, maybe ICU, or no, not anywhere. Okay, we're going to move on. I'm conscious of time and I've got a few more things to say. So temperature control. Hypothermia is recommended in guidance for neonates who experience brain asphyxia, certain adult TBI groups, and it's in the guidelines for the children who experience a cardiac arrest and they have return of spontaneous rhythm. It's recommended in certain groups for that as well. And the theory is that the reduction of brain metabolism is beneficial to an injured brain. However, 2 meta-analyses and 5 RCTs did not show a difference in outcome in traumatic brain injury. One study actually showed that the mortality in the hypothermia group was actually increased. And it's postulated that in an injured brain compared to a brain that has suffered a global uniform insult, like cardiac arrest or like asphyxia, an injured brain has patchy areas of injury, and therefore total reduction of activity is not actually useful. What is more useful is ensuring that the brain is not overtly stressed by fever. So in traumatic brain injury, sometimes temperature is dysregulated, and therefore strategies to achieve normothermia is recommended. Also remember that in polytrauma, hypothermia is especially bad. In combination with acidosis and coagulopathy, it's actually termed the triad of death. I mean, you can't get any more bad than that. Also within that is potentially hypocalcemia within that triad of death. Okay, right, next poll. I think somebody mentioned in the word cloud about immobilizing his C-spine. Somebody said, let's put a collar on. What are your thoughts on immobilizing him? Yes. Yes, yes. Okay, yes, yes. Yes is the answer. Yes, please. But maybe not necessarily with a collar. A collar in traumatic brain injury, particularly if it's put on a rush or it's put on by somebody who is not experienced, will actually impede venous return to the brain, will actually then inadvertently push up ICP. So perhaps collar and blocks or use your hands to do that. There are differences in anatomy in the under 8 years old compared to the older child who has a more adult looking C-spine. C-spine injury occurs in about 1 to 2% of bony injuries by itself, and associated with head injuries, it's about 2.2%. The anatomical differences are younger children have large heads with weak neck muscles. They have lax ligaments. Their bones look a little bit different, so they've got anterior wedging, and their facet joints are actually horizontal. The purple triangle actually shows where the fulcrum of movement is. So in a younger child, the movement of the C-spine is actually higher up. So if there's going to be any injuries, it's probably going to be higher up in that way. In an older child, it's lower down, C5, C6. And so the injuries, which is similar to an adult, and so the injuries are going to be around there. And there are some normal X-ray variations in the pediatric population as well. So how do we image them? Well, plain films can miss about 10 to 25% of C-spine bony injuries. Um, the so you think, okay, well, let's CT them. Well, CT scanning, unfortunately, can also miss soft tissue injuries. So it's really good at looking for bony injuries, but it can miss soft tissue injuries. And of course, because of these anatomical differences in children, there is this phenomenon of spinal cord injury without obvious radiographic abnormality that can occur. So if you're, and that can occur in up to about 35% of reported cases. So if you are concerned about a C-spine injury, then eventually, maybe not now in the ED when Bob is coning, he'll need an MR scan. It's quite a rare event, and it's more likely in polytrauma, and it's probably underreported because probably these children actually die from catastrophic injury at the roadside. There are some clinical decision rules around C-spine injury development, and there was a injury identification, and there was a systematic review available that looked at all the different clinical decision rules. So they looked at the Nexus clinical decision rule, the Canadian C-spine clinical decision rule, the PED spine one, the nice head injury one, etc., etc. And in that systematic review, the authors concluded that there was insufficient evidence to test the accuracy in children, particularly under the age of 8 years. So kind of because it was just low numbers that we reported. But there's a recent paper in 2024 by Leonard and his group, and they looked at developing a child-specific tool. They had a prospective observational multi-center study, and they derived and validated a clinical decision rule to use in pediatric C-spine injuries after blunt trauma. 9 emergency departments were in the derivation study, and then they validate it in a separate 9 other departments across the PECON network. And they had over 10,000 children in each group, and their reported C-spine injury rate was 1.9%. And their clinical decision rule incorporates these features, and it has a sensitivity of 94.3% and a specificity of 60.4%, which is better than anything we have available at the moment. Yara, am I all right to jump on? I appreciate that we've got some, I've got maybe 4, 5 slides left.
Okay, that's fine. You can
Is that right?
Yeah, that's fine.
Okay, perfect. Okay, so Bob's parents say that he injured his head only, but should you CT for other injuries? You can't really get that information from Bob because he's in a pretty dire situation in the emergency department. So when you're taking him for a CT of his head, I think we've just kind of said we're going to immobilize his spine. We're probably going to scan his spine. So we're probably going to do a CT scan of his spine as well, because we can't really assess it clinically because his GCS is really low. Are we going to ask the radiologist to CT scan the rest of his body? So 4 votes for yes. Okay, if there's no other votes, we're going to move on. Oh no, one person says no, it's too much radiation. I think somebody had mentioned EFAST in the in the poll as well from before. Okay, right. So Most say yes. One person says no. Well, we'll talk about it. So in a large retrospective data review by Jane Bayarutha, published in 2029, looking at UK data, it's probably one of the largest retrospective series around. She looked at 15 years worth of TARN data, and that included over 24,000 children who were injured. Head injuries, as discussed, was top the list as the most common injury site, and of course the most mortality. However, in about 40% of cases of head injuries, they were not isolated injuries. And a combination of head and thoracic or head and abdominal injury carried the highest mortality. So if you think about a car hitting a child, where exactly is that car going to hit the child? It's not going to hit them on the head first. It's actually going to hit them on the body first. So it's going to hit them on the body first, and then the head, unless it's a big van. So it's a big van, it might hit them in the head first, or a bus might hit them on the head first. But a smaller car will hit them on the body first, and then the head will either be hit onto the car or hit onto the floor. And there are some very well described patterns of injury. One is called I think it's called the Waddles triad, where the head is injured, the trunk is injured, so either chest or abdomen, and then a long bone is injured, just because of that pattern of how they are actually hit in that mechanism, and that carries a significant risk. Now, if you add on a reduced GCS, so you've got a head injury, it's a significant head injury, you might have a reduced GCS, the clinical team might not be able to elicit signs which you could traditionally elicit in a child who was able to tell you what happened and is able to tell you that their abdomen isn't sore or their spine isn't sore, etc., etc. So if you have somebody who has got a major significant head injury, then you have to look for other injuries. 40% will have another injury. And you're not going to be able to get any of that information from your clinical signs. If this child ends up going to theatre, so somebody is now going to operate on this child, technically causing more trauma, there might be more blood loss and things like that, and this child has a bleeding spleen that nobody is aware of, that's going to cause an absolute disaster in theatre. So these specific injuries need to be found. There's questions about EFAST. EFAST is very popular, so it's ultrasound scanning within the emergency department, looking for chest and for abdominal injuries. Very popular in adults, and in fact, actually, it's a rule in phenomenal. So if you see something, then you would go on to potentially get further imaging. However, no such evidence exists in children, and point of care ultrasound testing in children is really underdeveloped compared to adults. There's a huge variety of ages and sizes and to look for in a child, and it's not something that is done routinely. So I would move away from EFAST and I would scan the child. Probably for Bob, I might do a chest X-ray if there's no overt problems with breathing, saturations, or any external injuries. And I might do, and I'll probably do an abdominal pelvis CT scan with contrast. So let's get back to Bob. Well, he survived his injuries thanks to the quick recognition and the actions of the team. He was managed in the emergency department with a package of care. He had emergency neurosurgery to evacuate a large extradural clot. He spent 24 hours in the ICU postoperatively and 5 days in total as an inpatient, and he was discharged home with ongoing rehabilitation. His main deficit is a left-sided squint. In March 2024, Horn and his team looked at outcomes of children who had severe TBI in one centre in America, and they looked 1 year post-injury, and more than half of those children in his series had residual disability. It's about 63%, I think. And these outcomes, these disabilities included cognitive deficits, so memory, attention, executive function, behavioral issues, physical impairment, and academic difficulties. And these issues often emerge later as the child matures, and it impacts their social participation, and they may require further long-term rehabilitation. Now, if you recall what we said about injuries affecting those children who are of a lower socioeconomic class, then their life chances of getting a job, keeping a job, buying a house, all of that kind of stuff get completely reduced as well. So this is another insult to them. Okay, so in summary, we've talked about systems which help reduce mortality. We've talked about pediatric traumatic brain injury as a significant cause of mortality. We've talked about evolving diagnostics and management, specifically in severe traumatic brain injury, hypertonic saline, tranexamic acid, and try and keep measurements within normal. So normocarbia, normal oxygen saturations, normal temperature. And look for polytrauma, particularly in the child who has a significant severe traumatic brain injury. Okay, one of the last slides. What will you take away from this session? You just want to write one word about what you'll take away from this session. People are having a think about it. Be ready. Yes, be ready. It's going to come. It's going to come to an emergency department near you. LAP for TBI. I'm not entirely sure about what LAP means. And maybe that's an abbreviation that I'm not aware of. Anticipate the worst. Yes, but always hope for the best. The first 60 minutes are critical. Okay, that's great. Okay, thank you. Okay, so my last slide is thank you for listening. Thank you for engaging. Sorry we overran. Just a plug for our so in our department, in our hospital, we have a visiting professional program. You can come and do a clinical fellow or at any stage in your career. So even after kind of consultancy, the details are on the website, but this QR code will take you straight to it. Thank you so much. I'm going to stop sharing.
Thank you so much. Thank you so much, Dr. Shrouk, for an excellent, insightful, really presentation and talk, clear and practical in our daily life practice. We would like to receive a couple of questions from the audience, and I have a couple of questions from my sides. So, what are your top 3 practical pearls that can immediately improve outcomes in the ED during early trauma care and pediatrics?
So I think it's about doing the basics well. So recognition, I think recognition of what can happen to children and what potential complications can happen and actually anticipate those. So not be on the back foot and not kind of say, oh gosh, I didn't realize this was going to happen and I didn't realize this was, so actually to like, for example, in traumatic brain injury, to kind of anticipate that actually a GCS of 14 is abnormal when the paramedics call it. So even though he was hit by a car at a low speed, actually I'm thinking, oh, this child is severely unwell. I'm going to get everybody there. I'm going to anticipate that this child is going to be severely unwell, and I'm going to actively look for injuries. The other things are we've not really mentioned it, but analgesia. So good early analgesia is key to getting the child to be a bit more cooperative, to have a bit of trust in you, and to be able to examine them in a way that elicits clinical signs. Yeah. because anywhere where you touch them, they might be and then you
Yeah.
give them a little bit of analgesia, um, and automatically they're feeling a bit better, and they can converse with you, and they can tell you potentially what happened, and are able to describe exactly where it hurts.
Yeah.
And then the third thing is actually keeping the patient warm. Um, um, when a patient comes in, everything comes off. We want to find the injuries. Oh, the cannula goes in, whatever. And everybody actually forgets that this child has potentially been lying on a road for X number of minutes or hours, whatever, who has had to get in a cold ambulance, who has then come to a potentially cold emergency department. And hypothermia is terrible for trauma, terrible for polytrauma. It's included in that triad of death as one of the points. So put the blanket back on the child once you've examined that particular system. Keep this child warm.
Yeah, and I can't agree more about keeping the patient warm, starting ambiguous with an analgesia to allow you to examine him carefully. And really, this is an amazing practical pills that we will get a trauma care for our pediatric cases. Another question from the chat, Dr. Wahabi is asking, do you recommend CT chest and abdomen in severe TBI only? And another question, did you ever use tranexamic acid in peds TBI?
So I'll answer the second question first. Yes, we use tranexamic acid in pediatric traumatic brain injury routinely. It's our routine care, and it's expected in our system that is actually given by paramedics in obvious severe TBI by the
Mhm,
roadside. They cannulate them and they give them. If they haven't had it in the pre-hospital environment, then and we diagnose severe TBI, moderate to severe TBI in the emergency department, then we would give it. We would give it as a bolus, and then we would start a continuous infusion. Um, the first clot is the best clot. You don't want any more blood going into this brain, particularly if this child has signs. So yes, yes, we do. It's in our national guidance as well. So our Royal College of Emergency Medicine, our Royal College of Pediatric, RCPCH, have put out position statements recommending it in children. It becomes a little bit difficult when you talk about non-accidental injury in
mhm,
in in babies. They often present with severe traumatic brain injury, but the history is all a bit, well, when did it happen and when did you find them and what? And you really can't quite get a grasp on that. Outside of the 3 hours is, much less benefit. And I think it's a bit more nuanced in those cases. And I think if you gave it, you probably wouldn't be wrong. If you didn't give it because you thought it was over 3 hours, you probably also wouldn't be wrong. But there's a little bit of nuance to that. But if there's definite time, this patient has been injured, fell out of a window, run over by a car, something like that, and they have moderate to severe traumatic brain injury, the recommendation is please give tranexamic acid. We have years of data now of it, and
mhm,
there haven't been, if I can recall, in our centre, a complication from it.
mhm,
It is also routinely used in multiple different areas of the hospital. So cardiac surgery, infusions and infusions of tranexamic acid go in.
mhm.
This is a drug that has been used in pediatrics for a long time before it's come to trauma. The first question was, would I routinely CT chests and abdomens in traumatic brain injury? Um, in a low GCS, so anything other than 15. If there are if so, GCS 15, no other clinical signs, and the child can tell me exactly what happened. Yes, no, I didn't injure this. No, nothing hurts. No, 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 no. Yeah, not a bruise on them, and they've got a bump on their head, and they've vomited 3 times.
Mhm.
Nice head injury. Say yes, you'd have to scan that patient, but that would be isolated brain injury. I wouldn't necessarily be worried about their C-spine if they're able to tell me nothing hurts and I do a normal neurological examination on them. In a
Mhm.
child with a lower GCS, so 14 or less, then or a child with a dropping GCS, then I am particularly worried about C-spine injuries. So I would immobilize them if they've not, but not with a collar. I would use my hands or I would use blocks and tape because I don't want the veins to be occluded. And depending on clinical signs, whether I CT a chest, sometimes you get a lot of good information from a chest X-ray. Abdomen and pelvis, probably if they were hit by a car and they had a low GCS, probably. That would need contrast, which is absolutely fine. It's fine to do. The in a CT abdomen, they actually include a significant amount of chest. Yeah, because the
Mhm.
diaphragm curves like this. So you actually get quite a bit of chest in there as well. And if there's any abnormalities there, then you can extend it if you're worried about that. I hope that
Mhm.
answers the question.
Yeah, amazing. Clear, to be honest. But I have a question regarding the tranexamic acid. Actually, you have mentioned that there's Crash 1, Crash 2, and Crash 3 trials. Along with that, the TikTok trial. I think they did not finalize the results yet,
So
right?
Crash 3 they have.
Huh,
Crash 4, so Crash 1, Crash 2, Crash 3, yes.
huh.
Adult patients. Crash 4, you're going to ask me about my literature review. I can't quite remember whether Crash 4 has been published or not. It's an adult study, so I'll get to it eventually. I'm a pediatrician by heart. Um, TikTok, I can't see that it's actually when I was looking, I can't see that it was actually open and recruiting, but it might be that my search for it isn't adequate. But they have published their feasibility results. So can they recruit to a study like this in America? And I think they said that they can. They recruited 30 patients overall. It was a three-armed study using four pediatric emergency departments. And but in order for them to be able to have meaningful results, they need about 2,000 patients.
Yeah,
So it's going to be, if they do go ahead for it, it needs a lot of funding to be able to do that. It'll go on for quite a while. However, in the UK, because of the Crash 1 and the Crash 2 and the Crash 3 studies, it's such overwhelming evidence that we've said, and Europeans have said, and Australia and New Zealand have said, use it in children. Um, but particularly, like if you look at the patterns of injury, there's three patterns of injury in children. One is in the under ones. Yeah, somebody drops them, there's non-accidental injury, something like that. Yeah. I'm not really talking about that age group. There's another mode, which is the 5 to 7 years. Yeah, they've
yeah,
discovered that they can ride a bike. They know how to unlatch a window and
yeah,
fall out of it. They run out onto the street, etc. Yeah, and then it dips again when they start, listening to their parents. Don't run out. They understand all of that, and then it increases again in teenage years. Yeah,
yeah.
and teenage years are, the risk-taking behavior. They're the larger group. The teenagers are the larger group. And if you look at some of the boys and some of the girls that come into our emergency department who are 12 and 13, they're they're taller than me. They're bigger than me. So you kind of think, okay, well, it seems reasonable to extrapolate adult data to somebody who looks adult-like. Yeah.
Exactly.
So
Yeah.
I can understand that. But like I said, we routinely use it now, and and we use it in the pre-hospital environment, and we have years and years worth of information. Somebody needs to sit down and do a massive retrospective look at it.
Yeah, I
Um,
think so. I
yeah,
think which is the best because in our protocols or policies in Saudi, I think we don't have a trauma panel which includes the trauma management, includes the tranexamic acid, like the European and the others, especially in the ATLS, they have been recommended in their guidelines for the adult perspective, but it's not for a
yeah.
pediatric perspective. But this is an amazing idea that it's a gap for literature to do research about it. And for us, especially in the Middle East, with cooperation with the Europeans, especially with you, Dr. Shuruk, for doing some research related to the tranexamic acid with a multi-center. That's really an amazing idea.
Yeah.
There is another question from the audience in the chat. So, from Dr. Altaf, how was screening for concussion done in pediatric head injury patients? How effective and important it could be as a screen method if devised or advised, I think he means.
Yeah, concussion in pediatrics is an absolute nightmare, to be completely honest. It's an absolute nightmare at the moment.
Mm-hmm.
Um, because we don't have a definition. So who can define what concussion is in a child? Nobody has a consistent definition. It was driven by so the all the studies that have come out on concussion uh, probably in the last 15 years have come out of the United States, which have a different healthcare system. And their healthcare system is and their society is driven by sports and it's driven by private health insurance.
Mm-hmm.
So there was a litigation element to that, which drives you. So you kind of think, well, what, how does it work in a system which is very different? Can we apply the same principles? And then on top of that, sport really pushed forward concussion research in adults, and it's much better in adult services than it is in pediatric services. So, for example, in the UK, we have adult concussion clinics, but we don't really have pediatric concussion clinics. And I think there's some biases around kids are always falling over and bumping their heads. You know, it's mild, it's a mild head injury, when actually there's a bit more nuance to that. The GCS doesn't help in finding out that kind of granular kind of information. And then when a child does have some symptoms of concussion, we don't really know how to diagnose it. We don't really know which interventions are beneficial in following a child up. And what we also don't know about is repeat head injuries in a child. So a 2-year-old might fall over. How do you know that they're concussed? Well, they might vomit. They might want to sleep for a little bit longer. A 7-year-old, you might kind of think, okay, they're a little bit more, there's some overt signs, they're not as active as they normally would, or they're complaining of a headache. And then in an older child, there might be some issues with their schooling and their affect and their mood and things like that. But if you look at that 7-year-old child, they still have a lifetime of still being a child, and they might fall over and bang their head again. And nobody understands the effects of repeated head injuries in children as well. So there are some scales which are validated in children. I've forgotten what the name is now. It begins with S. It's a concussion checklist. Ask a lot of questions. Do you tick this? And you grade themselves, and you can use it repeatedly over the course of months. And there are various different types of checklists like that. And some of it is self-reporting, some of it is observed. And we try to utilize one of those checklists in the emergency department on children who we thought might have concussion. So not on everybody who's had a head injury, but who might have a concussion. And per child, it took about 25 minutes to do. It's impossible. In an emergency department that sees 200 to 300 children a day, you're not going to spend an extra 25 minutes trying to do a concussion scoring on somebody. So these tools are really good, maybe as research tools or as clinic tools, but in terms of diagnosing it in the emergency departments, we might have to look elsewhere. This is where neurobiomarkers might actually come into play, because neurobiomarkers can measure microscopic kind of releases of brain damage in blood, and you can measure it. Yeah, that's what's happening in adults. There's a study at the moment called the Brains TBI study. It's a £9 million study led by Virginia Newcomb in Cambridge in emergency departments around the country, adult emergency departments around the country. looking at point of care testing for neurobiomarkers and concussion diagnosis, and how do we bring that into emergency departments and relating it to any imaging. And there's some other kind of outcomes that they have. It's only just started in the UK. So in adults is really moving forward with independent um, kind of objective measurements of brain injury. That
Mm.
same thing, I think, needs to happen for children because, particularly for a very young child who you might not be able to express themselves or things like that, measuring from a drop of blood in an emergency department, which takes 15 minutes, less than the time of the survey, yeah, it takes 15 minutes to do, might actually indicate, oh, this child needs follow-up. You can't see anything on the CT scan or they're neurologically normal, but actually that's reached the threshold. That child needs some follow-up. They need some neuropsychology support. They need the school to be aware that they need some time off, but also that not to pressure them with their homework and et cetera, et cetera, et cetera.
That's amazing. But I have a question regarding to the biomarker for concussion. Is it expensive? So it's expensive.
Um, yes. So anything at the beginning is expensive. There are different machines. So the Abbott Alinity iStat machine has a device, and it's the specific cartridge that you use. So you
Mhm.
can interchange the cartridges. You don't have to buy the device. Again, you can interchange the cartridges, and they do other types of biomarkers. I think they do troponins and CRPs and things like that. Yeah. Each cartridge, so a box of, oh, you're going to have to do some maths for me. A box of 25 cartridges costs £1,000, a
Thousand.
thousand British pounds. So each
Uh,
cartridge costs how much? A lot. It's a lot.
yeah. Let me calculate in Saudi riyals. How much does it cost?
Okay. All right. Um,
Uh, uh,
the device itself, the handheld device itself, the actual device itself costs 8,000
yeah.
British pounds.
So actually, it costs at least 1,350 US
Okay.
dollar. So 1,350 US dollars to Saudi riyals, it will be
Divided by, I was going to say, divide that by 25 though.
okay. So it's 5,000 riyals for 25.
Okay. All right. But you're not going to use it on everybody.
Huh.
You're going to try and use it on children who the theory is, there's no evidence out there. The theory is who you might save them from having a CT of their head.
Mm.
Yeah.
Yeah.
You might save them from coming to repeat appointments. They might come back to the emergency department a week later saying, oh, they still have concussion. What do they do? Or something like that.
Yeah, you're right.
The savings might be later on down the line. You might admit them for observation because you don't want to scan their head. Oh, they don't reach the threshold yet. I'm going to admit them for 6 hours, 8 hours of observation,
Oh,
24
wow.
hours of observation. How much does a pediatric nurse cost? How much does a pediatric bed cost? So these are all things to consider when instituting something like a point of care test.
Mm.
However, at this moment in time, the evidence isn't there. So don't buy anything at the moment. Maybe buy it for your adult adult patients, but not necessarily for children. But um, there are other companies which do neurobiomarkers. The other company that comes to mind is bioMérieux. They do a point of care testing, but their machine is much bigger.
Mm.
And it's the same turnaround times. But there's things on the market that are validated all for adults. You can just buy it off the shelf, all for adults.
Mm.
Not very much at the moment in children. I conducted a study last year. We recruited over 400 patients who came through our emergency department with any level of traumatic brain injury. So severe, intubated by the roadside, kind of brought in, or ran and bumped their head against the door frame, didn't even get knocked out, just had a very small bruise. We took blood biomarkers from them. And then we gave them a follow-up. We followed them up for 3 months using text messaging. And we've completed all of our data recruitment, and we've got the data set now to analyze. And what we did was we used the Alinity, the Abbott Alinity machine that measures GFAP and UCHL1. It doesn't measure S S100B. It just utilizes those ones. But of course, it's all designed for adults, so it has the adults reference ranges in it, and it has, when it says high, that's based on adult reference ranges. But we've used it. It'd be interesting to see. I'm interested to see what our results are. But that's what the French study did when they looked at 700 over 700 patients, and they said it correlated well. So let's wait and see. A lot more work. I reckon in the next 5 years.
No, I'm looking forward for that article, to be honest, when it's
Yeah.
published. Please kindly share it with us.
Yes, yes, I will. Yes, I will.
That's amazing. Last question by Dr. Muhammad. He's thanking you for the amazing presentation that you have giving us. And he's asking, do you think a community-based first responder system in pediatric trauma could reduce the pediatric mortality and morbidity?
So what I would say is that even basic first aid in people who have sustained major trauma can result in an altered course for them. So, stopping bleeding, because, um, opening an airway, these basic things can actually change trajectory. So increasing the number of people who are aware of what to do in basic first aid, the parents, the teachers, the football coaches, whoever it is, the police officers, et cetera, all of that kind of stuff around is naturally going to help in that situation. In terms of formal community-based responses, there's only there's a limit that you can do out in the community. Yeah. In a place like the UK, you're not too far away from a hospital. So, it was a small place and things like that. But places which have vast geographical areas, Australia, New Zealand, America, maybe Saudi Arabia, who have pockets of communities where there's not a hospital for hundreds of miles. How do you affect their chances of survival if they have sustained trauma? So the model of community-based care needs to be tailored to each situation. But the more rural it is, the more expensive it is, because what you're going to be doing is you're going to be instituting different types of services, different types of transportation. You're potentially going to rely on helicopter or fixed wing aircraft to transfer people from one place to the other in minutes, because these minutes count. Yeah. You want something fast. By road, it might take 3 hours, but by helicopter, it might take 20 minutes, etc. Things like that. And then you have to have all the training and which goes with it. I think that, yeah, there's only so much that you can do in the pre-hospital environment before they need to get to a hospital. But shortening that time, being able to have people who are um, able to institute some interventions that will save a life. The tranexamic acid, is one of them. People who know how to manage an airway, so that the paramedic systems know how to manage an airway. They know how to cannulate. They can give a certain amount of drugs. Tranexamic acid is one of them. They can give some morphine if somebody's in terrible, terrible pain. But what you don't want them to do is you don't want them to spend 3 hours, with a patient when the hospital is only 30 minutes away. Unless there's a specific reason, unless this person is trapped in the car and the fire crew have to come and cut the car out, and things like that. But actually what you want is the team to be there to be able to still institute treatment while that is happening. There's layers to it. So you have the people who are able to do basic first aid, then the people who are trained, but that training is also in different layers. There is a specialist group, and in more mature healthcare systems, they have this, which are doctors who are trained in transport in pre-hospital medicine, and they will only be called to the roadside in very specific circumstances. So if there needs to be an intubation, or if there needs to be more drugs, or blood needs to be given, that can all be done. They're rapid responders. They're ready to go at any moment in time, and they often fly around in a helicopter.
Yeah. Yeah, and can't agree more. You have mentioned the packed RBC to be given pre-hospital,
Mhm.
and nowadays we have seen a lot of projects regarding the packed RBC has been saved lives, a lot of lives,
Yes.
especially in our area and even abroad in Australia, New Zealand, and
Yeah.
even UK, which adds a lot into the literature, especially in adults, not in peds. But it's really an eye-opening, and I think this is one of the greatest questions that we have received today, and the greatest answer from you, Dr. Shuruk. I think we are coming to an end. Thank you so much, Dr. Shuruk, for an excellent and practical session. And with that, we will conclude today's meeting. Thank you, everyone, for attending. Thank you, Dr. Shuruk, for your time, efforts, for giving us this amazing discussion, amazing presentation. And by that, any last thoughts?
I just wanted to say thank you so much for inviting me. It's been an absolute pleasure to do this. I'm sorry that I've overran. I appreciate all of your times and what you're doing. And I hope to see you soon, either online or in conference, or come and do a clinical
Of
fellow program. Yeah, in
Of
our
course, count me
department.
in.
Yes.
Count me in. Of course. Thank you so much. Nice
Thank
to
you so
meet
much.
you.
Thanks
Nice
for your
to have
time.
you aboard. Thank you. Thank you.
Thank you.
See you.
Bye bye.
Bye.